Welcome everybody. Nice to see some people back again. Nice to see some new faces here today. This is our 4th grand round. We've been doing this since July. We had a month off for August. Over the last few months, we have covered respiratory, we've covered cardiology, we've covered gynecology, and now it's the turn of Lindsay Smith to talk about ENT today. So just a few ground rules and talk about why we're doing this. We have some new people who are logged in remotely from different bits of the country. So welcome, and really for your benefit. Why are we doing this? We are doing this because a lot of our training posts over the last few years have gone. And so the level of community specialist training is very limited now for our doctors as they come through hospitals. So we have set up, in conjunction with Samuel West Birmingham Hospital, a number of different community specialities around gynecology and ENT and orthopaedics and urology and respiratory and cardiology and dermatology and rheumatology, and the list goes on, and it seems to grow by the month. And actually, we have some fantastic GPs with extended roles who are leading these services, who are working alongside our consultants, creating new care pathways and bringing a number of procedural bits and diagnostic bits that have traditionally been done in hospitals out into the community. Actually, for most of our trainees that come through training, the idea of wanting to become a GP, what sort of GP do you want to become? Do you want to be a partner? Do you want to be a locum? Do you want to be a salary GP? Do you want to be a GP that has an extended role or has some sort of special interest? And actually, we're starting to see huge enthusiasm for extended roles in all of our trainees coming through the system. So coming along to these grand rounds is a great opportunity to meet our GPs with extended roles who are doing some of this, to talk about how you guys can start to develop in those directions. Maybe you want to spend some time in specialist clinics, you want to learn more. This is also an opportunity today to bring clinical cases if you want to, and it's an opportunity to think about how we can change and improve some of our care pathways that we've got as well. So we do this locally with lunch, but actually we're now a national organisation. So we've opened this up to all of our modality practices, to all of our modality trainees nationally now as well. We've opened this up to the VTS schemes for the people that even aren't in our practices, local GPs working in the area in training for education and development. All the videos from all the ground rounds are available online. I will make sure that you get copies of the presentation sent out to you afterwards. There is a conversation about previous presentations. Some people haven't had previous presentations. Thinking about it, I will get a link sent out to all of today's attendees with a SharePoint link as to where they can be found, so you can download them. That might be easier. So, with no further ado, I'm going to hand over to Dr. Lindsay Smith, who is going to take everybody through common problems in ENT. Oh,
that doesn't really matter. Yeah,
there you
go. This is where they. What is that? The camera?
That's the camera. No, that's the microphone.
Okay.
They can't see. They can just see your slides.
Okay. Sit or stand?
It doesn't matter.
Okay, I'm going to sit. Okay. Hello, everyone. Thanks so much for coming. I am Lindsay Smith, one of the GPs. I'm based at Lorry Pike. Been doing this ENT service since 2014. So a little bit about our service, first of all, before I talk about a handful of things that I have written about. So at the moment we have 8 clinicians. So there's 3 GPs, including myself, and 4 consultants, and then 1 nurse practitioner who does the wax clinic. We have at least 6 clinics a week running across 3 sites. So Nishcam, I don't know if you know, just down the road on the Soho Road, Atwood Green, which is sort of towards New Street, the city centre, Bath Row, and I do a clinic each week at Tipton, the Black Country Family Practice. One thing that's really great, I think, is the fact that we have these very close links with a consultant. So all the specialties have some sort of consultant mentor. Mine, the chap I work alongside is Mr. Beach. He works at the QE. It's great. Basically, he's a really nice guy. Every month we do a joint clinic. So sort of, in inverted commas, problem patients are the ones that perhaps I've treated or any of my other colleagues in the ENT clinic have treated, and just want him to have a look at. He does his clinic, I do it with him. So I basically get free ENT teaching every month, which is great. one other thing is that we've just started up this wax removal clinic. So ear syringing is now no longer commissioned in general practice. So it's really great that we have this. She's lovely, Santosh Shakar. She's a nurse from City Hospital, and she's helping us do the wax clinics because we have that many wax patients to put them into the general clinics would take up basically all our time. So yeah, do remember that. And I put at the bottom, coming soon, our own Modality hearing test booth. So we're trying to set up our own audiology centre at Nishkam, which will be really useful. Okay. Okay, so coming on to, this is the referral criteria. I mean, I won't go through each individual case. The exclusion criteria is basically the ones you want to know. It's the red flags. Okay, so anything, you know, prolonged hoarse voice or sudden hearing loss, anything like that, it's best not to go through. You know, they're the ones that need the 2-week wait straight into hospital. Other than that, we pretty much see most things. Okay.
What's the age range?
I'd say, yeah, good question. I think on the referral criteria, it says 5 and above. To be honest, we see younger than that. It depends what the problem is as well. Feel free to refer, because if I have advice, I prefer just to give it back than just bounce it. I'll probably just advise, because I go through all the referrals myself. So it's best just to refer, and then if I can offer advice, as I say, I will. Okay. So I mean, if you ask someone to do ENT in half an hour, or any subject matter for that, you know, on that, it's pretty difficult to cover everything. So I just picked a handful of things, and it's not an exhaustive list by any way, shape or form. They're just some of the common presentations I see. So perhaps I could just offer a little bit of advice. I'm sure it's all revision. Everyone knows it anyway. Okay. So the first one is rhinitis. I see a huge amount of rhinitis. Rhinology, study of the nose, anything itis is inflammation. So it's an inflammatory response to the lining of the nose. It can be allergic or non-allergic. Allergic seems to be the most common, but just for information, non-allergic, things like acute infections. You get a cold, the lining of your nose will inflame. Drugs can cause it, hormones, so pregnancy. A lot of women complain of having blocked noses throughout pregnancy. That's really common. Vasomotor rhinitis, often to stereotype, it's the sort of 70-year-old man, and when they start to eat their food, their nose starts to drip. That's a common one. Or idiopathic. I'm going to talk a bit more about allergic rhinitis. So most people know it as hay fever, or don't know that allergic rhinitis, is hay fever. So that stems back to when they used to harvest the hay in the summer. They had runny noses, they thought they had a fever. So that's where the term hay fever comes. So if you ask a patient, do you have hay fever? They say yes. Or, you know, and then you ask them symptoms, and actually it's allergic rhinitis, and they say, no, I haven't got any allergies. So it's, you know, it's just one of those things I like to just say. Perennial, all year, or seasonal. So some people are worse in the summer. And this intermittent or persistent, mild, moderate or severe, that's based on these ARIA guidelines. So that's allergic rhinitis in relation to asthma. So intermittent, if they have it for less than 4 days or less than 4 weeks, you class it as intermittent. Persistent is more than 4 days and more than 4 weeks. And mild or moderate and severe. So mild, they don't really notice it, you know, just a little bit of sneezing in the summer or something. Moderate and severe, probably likely to need more treatment. Now, the whole point of all this is so you can have a stepwise progression with your treatment. Okay. Classic symptoms, blocked nose, lots of runny nose, rhinorrhea, like the tap's gone on, sneezing and itchy eyes and nose. Signs, well, I put external, that's not so much to do with allergic rhinitis, but it is important to know, because if you've got a really deviated nose, you're really not going to get very far with giving treatment anyway. So it is always worth, you know, looking at the nose from the outside. Now, those two pictures, the one on the left, that is as you literally look in. So you could just do that with an oroscope. You just sort of ask them to look up into the sky, look up their nose just with your oroscope, with a light. If they're really inflamed, so these turbinates, and I'll get to a picture of the anatomy in a minute, you can see it, and it's red and it's fleshy. A polyp, unless they're massive, really massive, you're not likely to see too obviously with an oroscope, because the beginning stages are often right at the back of the nose, but they're typically white. Okay, as you can see on the right, it's not that obvious. I guess. But so in the clinic we use a nasendoscope, which I've got here, but for the sake of those people who are watching online, I'm not going to bring it out now because obviously they can't see it, but I'll show it to you later. So this is a very little bit about anatomy. I won't dwell on it too long. Oh, you can't see anything. So is this pointer work? No. Okay, so 2 eyes. So the picture on the left, 2 eyes. Then there's the nose, obviously, in the mouth. You can see at the bottom. Is it worth me pointing on that?
Yeah.
Yeah. Okay. So we all have these bones. These are turbinates. There's the left nostril. There's the right nostril. Superior, middle, inferior turbinates. Okay. So that's what you talk about when you say inflamed in turbinates. Surrounding the bone is the pink fleshy lining of the nose you see when you look up the nose. So that's what we're talking about, these things. They basically increase the surface area of the nose. So you humidify the air, catch all the dust particles. That's, we're primarily nasal breathers. This is normal. So you're looking through the camera, black hole where they're breathing beautifully, normal turbinate there. As you go along, you can see this is getting bigger each time. That's the inferior turbinate. It doesn't happen overnight. This is going over a long period of time. Okay, so enlarged may not have any symptoms really, maybe a bit blocked at night. And then that one, that's the point where they come and present and say that I'm just so congested. The reason why you're always worse at night is because when on top of that, if you imagine when you lie flat, all the blood flow to the head, so all your vessels become more engorged at night. So they normally say, oh, it's really bad at night, I can't sleep very well. Okay. That one is just a picture of what they can do is shave it off. It looks really glamorous and what an easy fix. Actually, it's not. Even though you think if you take away the obstruction, you should breathe better. In reality, it doesn't really work like that. And the turbinates do grow back. So it's not a fail-safe method and it's not something you go to lightly. Okay. Next, so management in general practice. So there's lots of steroid nasal sprays. The point of the steroids are they shrink the lining, and that's basically what you want. So there's 2 arms of treatment, something to shrink the turbinates, and then you have an antihistamine to dampen down your body's response to the allergens. Okay, so you've got the fluticasone or the Avamys, the memetazone, which is Nasonex, versus, and I put versus Beckinase. I think on the ARIA guidelines, they keep going on about Beckinase. It's really cheap, I know, but actually, if you look at the bioavailability, so that is the amount of drug that you put in that actually goes into the system, your whole system, it's much, much higher for Beckinase. So, and it's twice daily application. You can get away with once daily for fluticasone or mometazone, and it's primarily on the nose, which is really important, especially things like if you've got a patient with glaucoma, you have to be careful about giving steroids to those people.
Mometazone is generic, so it's not much different price-wise to the...
Now, yeah, it has definitely gone down. You're absolutely right. You can actually buy fluticasone, so it's Pyrenees. That's how it's, the only problem was Beckinase was the only one that was over the counter. So now we have at least got fluticasone, which is Pyrenees, which is lovely. Please use for 8 weeks minimum. So it's not an infection that you're trying to treat. A week will do nothing. And a lot of patients use it for a week or 2 max and say it's done nothing. It won't. And you need to tell them that and be mindful because compliance is always an issue with all these things. I've put nasal douching. So that's essentially a sinus rinse that you go up one nostril. You can YouTube it. Everyone uses the internet now. Hey, we're on YouTube now. You go up one side of the nostril, it comes out the other. Not salty water. A lot of people use salty water, which I think is bonkers. Imagine if you go in the sea and you get salt up your nose. It's horrible. So the sinus rinse is essentially water, sugar, salt, and bicarb, and it's really soft. So it's a lot more tolerable. Okay. Antihistamine at night, I've put. Although they're non-sedating, a lot of people do find that they do feel sleepy. So I always just say, just take it at night, because if you're trying to do things in the day and you feel sleepy before you start work, it doesn't really help. Allergens, there's no role for skin prick testing. If you want to, but you really don't need to. It's probably more something we do in the ENT clinic. It's the RAS testing, which is just a simple blood test. 5 common ones we do: house dust mites, I'm trying to think now, tree, grass, dog and cat. They're the 5 that we tend to do. And in capitals, I've put correlation with asthma. Again, this is the ARIA guidelines. The link with asthma, they say, it's one airway basically. So it goes all the way down, and just check their use of salbutamol, because when they're really stuffy, you suddenly find that they're using their blue inhalers a huge amount. Okay, so it is important just to because obviously that's a really big issue. Nasal congestion in children. Now, the reason I put this, so allergies in children definitely can happen. I'd say under 3, it's less likely to be an allergy. So just be wary about congested children. The point of this slide is more to do with things like adenoids. So the classic presentation is a young, well, not necessarily young, so a 6-year-old who comes in. They're really skinny, okay, small for their age. The reason being is, so the adenoids are the tissue that grows at the back of the nose. And if it enlarges, it's like having a permanent cold. So this poor child can't really taste like you do when you have a cold, has no interest in food whatsoever. They have no enjoyment out of taking it. Every mealtime is a battle. So they tend not to eat. It takes hours for them to eat. They really sleep badly because they're congested at night. And you find that they either fall asleep in the car on the way home from school, or they're still napping through the day. Behavior can be a bit intermittent because they're just basically overtired. So I know you can't see adenoids in general practice, I get that, but the history probably will tell you more than anything with a scope. And actually, a lot of children don't even tolerate the scope. So you can trial nasal steroid spray, and it's okay. I know it's off license. They don't like to give it to under 12s, but you can just reduce the dose. 1 spray of the fluticasone each nostril once a day is fine. What we do in clinic is sometimes use betnazole steroid drops, 3 drops each nostril for about 4 weeks, and then just bring them back. And you can get some amazing results just with the drops, and it's safe as well for that short period.
Can I just,
yeah, sure.
At what age can you sensibly use a nasal endoscope on a child?
Oh, it's tolerable. It's whether they tolerate. We do have the spray. I'm less confident. So you can get 6-year-olds who, yeah, they'll tolerate it. And sometimes they're better than adults because it's almost as though they don't want to do anything naughty and move. It's amazing. So you'll be surprised. It's not that far, actually. It's a tiny amount that you could possibly see.
I've seen it done on kids. I was on ENT at City, and we used to do it on kids.
You'd be surprised, actually, that they tolerate it better than adults a lot of the time.
Mum and dad is on there. In terms of the adenoids, kids with really severely enlarged adenoids can get quite distinct facial features, can't they? They can have almost like a sort of more swollen, puffy cheeks.
Yeah, I mean, they're the ones that will probably go straight in. I mean, you can still try. So even if I do the referral, I still say, well, you may as well try the steroids. It's not going to do any harm.
It's just, I remember them when I was in clinic in ENT. As soon as they came in, they could talk to them. They've got like enlarged adenoids because of
yeah, they do.
Such distinct features. Do you have any pictures of that, by the way?
I don't know. No. I haven't seen them that distinct, actually.
Yeah, I've seen a couple, but again, I was on.
Yeah, they come in especially. Yeah, sure.
Do you think that there's voice changes? I remember my nephew had his adenoids removed, and suddenly from being a sort of 50-year-old man at the age of 5.
Yeah,
like
they do. Because they mouth breathe all the time. And if you imagine mouth breathing all night, it does. It really affects your voice. It's amazing. I mean, that's not to say everyone needs an operation by any way, shape, or form, and that's really important to know. They wouldn't be funded because they're a procedure into clinical value at the moment. Exactly. But there definitely are the cases where you think, oh, you poor thing. Yeah. Anyway. So we're going to sinus disease now. Now, what is the point of the sinuses? That's a good question. So we have 4 pairs. They essentially sitting around the face. The biggest ones are here, the maxillary ones, okay? They assist in controlling temperature and humidity of the air that reaches our lungs as you breathe through, produce mucus and moisturize the nose, and it's always written here, lighten the skull. I guess it is a pretty big bone, really, isn't it? And apart from your brain, so yeah. So sinusitis, anything itis, an inflammatory process with the lining of the sinuses. Now, the majority of them are nose related. And the reason I've said all this is because when you go to treatment, I'm sure you already know, a lot of the guidelines are use a steroid nasal spray. So there is method to using a steroid spray. Usually, as with most things, viral in origin. So what happens is, if I probably should go back to that other, can I go back? Yeah, so here, this is an ostia. So the sinuses drain in here. So, well, not all of them, but there's the maxillary ones here. So what happens is, as you breathe, if you have a rhinitis, so inflammation here, or a big polyp that's sitting here, you effectively block the drainage here. So you get all this buildup of mucus, and you can get secondary infection there. So that's one way, and a common way people get sinusitis. go back to it. So as I've said, yeah, mucus retention basically. So acute, so you get that really important in the history is the colour of the mucus, the colour of their snot. It's normally green or yellow or purulent. So it's not just a normal, drippy nose. Can be quite tender because if it's all blocked up here, there is some tenderness there. Fever. Chronic rhinosinusitis is more than 12 weeks duration. Inevitably, it's a failure to resolve from an acute case, usually an underlying pathology like rhinitis or polyps and things. So usually resolves in 10 days to 2 weeks. We've all had the patients that come in, they're not happy, they're pretty unwell, a lot of pain. So give them some pain relief. It's really important to sort the pain out. Topical nasal steroid, as we've discussed before. You can use decongestants. There isn't a lot on NICE. I mean, they have all these trials about whether you should or shouldn't use decongestants or douching. I don't think there's any problem in using them just for a short period. If they're really blocked and can't sleep, well, why not? It helps. Douching, again, if there's a lot of mucus, it can help get rid of the mucus. And there's no medicine in it per se, so there's no limitation on how many times you can use it each day. And then you use the spray once you've got rid of all the rubbish out the nose. If symptoms persist or they get worse, now the first line is actually penicillin, Pen-V. A lot of people think it's amoxicillin. They changed that about 18 months ago, I think. So it's Pen-V, 500 QDS for 5 days. Or if you think they're really bad, so, fever, all the other symptoms, just give them some Augmentin, co-amoxiclav. Okay.
Is that 5 days as well?
Yeah, they're 5 days, yeah. Okay, this one's a bit longer now. So disorders of balance. This was on the request of the lovely Dilsha Singh, probably because you get a lot of dizziness in cardiology. So let's try and keep it relatively simple. Okay, so we do get a lot of dizziness. That's the classic symptom. I'm really, really dizzy. Now that encompasses so much. Okay, so as we go through, as I'm going to say, history is really important before you do anything else. So your vestibular system, your balance system, has lots of input. So eyes, ears, your joints, the proprioception, and cerebellum. So imbalance as vertigo, that's a classic sign of vestibular dysfunction. So that rotation, they feel like the room's moving or they're moving. Lightheadedness, that's, that could be postural hypotension, cervical spondylosis when you look up and, they feel dizzy when they're looking up. Unsteadiness, age as well, one thing, peripheral neuropathy, think of all these sort of things. Loss of consciousness, blackouts, rarely ENT. Okay, you got to think other things if people are having blackouts, things like cardiovascular causes, neurological causes. So history, yeah. So mode of attack and mode of onset and duration. Are there any changes in hearing? Sometimes when people, if it's to do with the balance organ, they find that they're really muffled when it comes on. Okay, and they sometimes have tinnitus. So you think you're hearing noises, it can be one ear or both ears. And I've said that oral fullness. So like there's cotton wool in your ears for that time when you feel really dizzy. Some people feel sick. It's a bit like having motion sickness. It's not very nice. Is there any relation to activity? So if you turn in bed, that's a classic. When I turn on my left, it's really bad. So I tend to avoid that side. Effects of darkness is a good one. So vertigo is always worse in the dark. So when they're in bed at night, lying down, and they want to go to the loo and it's really dark, they tend to say that's when it's really bad. And I'll tell you about that, why, in a minute. As I've already said, cardiac history, drug history, alcohol, intoxication, and anxiety is another one, hyperventilation, things like that. So duration of symptoms. So if it's seconds, you're thinking more of this benign paroxysmal positional vertigo or BPPV. I've said about the hypotension. If it's a bit longer, think Meniere's or labyrinthitis. So they tend to last, it puts that person to bed often for half a day, maybe longer. If they're going on for a lot longer, you've got to think about, was there some labyrinthine failure? So your balance organ is just not compensated, okay, or some other vestibular disease. Anything to do with balance tends to improve over time. when they ask you how long will it take, well, that's the $1 million question. I don't know, and nobody does know, and everybody is different. It tends to be how you compensate, okay, how well you compensate for it. So if you go on a roundabout and you come off, you do feel dizzy for a bit, but you're able to, settle yourself down after a while or come off a boat. When you examine them, check the ears, check the eardrums, anything there. Nystagmus is really important. So horizontal tends to suggest some sort of peripheral balance problem. If it's vertical, less so. Okay. Check the cranial nerves. We do this, cerebellar function as well. Lying, standing blood pressure is important. The positional test, the Dix-Hallpike, is really important if the history is suggestive of BPPV. It's not, you don't have to wait for an ENT referral for that. The Dix-Hallpike, you can just look at that. That's just for the diagnosis. So for any of you don't know, D for diagnosis, EPLE is the procedure to try and cure it, okay? And the Dix-Hallpike is when you're just bringing them back off the bed and just looking for nystagmus on both sides. Now the Romberg's test, again, all these tests are not hugely sensitive or specific, but altogether they will help, just see if your history and what you think is wrong is true. So the Romberg's is when you're standing up, eyes closed, feet together. What you're looking for is to see whether or not they sway. So again, that goes back to when you're worse in the dark. So if you think about, you need your vestibular system, proprioception, and vision to stay still. So if you take away your vision, so you close your eyes, you've only got 2, proprioception and vestibular function left. So if you're standing still, well, for sure, then it's unlikely to be any of the other 2. Now the Unterberger stepping test is just a progression on from Romberg. So they're standing up, eyes closed, and now you want them to march on the spot. So that gets rid of proprioception. So all you've got left is your vestibular function. So if they start marching for a minute on the spot and start to either drift to one side, that tends to suggest there's a lesion on that side, or if they drift forward, that's another, again, not hugely sensitive, but helpful too. Again, the head thrust test, that's just, you hold their head and then you're shaking it gently, and then you turn it quickly to one side, and your eyes should fix on a point. And sometimes you can see a delay in their eye movement. Okay, it's always difficult to say this without doing it on a patient. So management for acute attacks, just use a vestibular sedative. You can do something like Stemetil, but please don't use it for about 10 days as a reducing dose. You see these whopping doses that go on for sort of 4 or 5 weeks at a time. Now, as I said, one of the abilities to get over dizziness and things is you need your central compensation. So if you're on Stemetil the whole time, you really are dampening down your body's ability to compensate. So just do, 5, depending on the size of the patient, 5 milligrams 3 times a day, or 10 milligrams 3 times a day for maybe 3 days. Bring it down to, 5 milligrams, bring it down over, 3 days at a time. Reassurance, it will get better. There is a leaflet you could print out. If you Google Cawthorne-Cooksey, they are some little exercises you can give for the patient to do at home, just to help with their vestibular their balance, basically. Or if they've had BPPV, there's the Brandt-Daroff exercises. They're just information leaflets that sometimes are really helpful to some patients that they can read up on and do at home. Consider bead testing. You can do. There's nothing wrong with it, just for a trial period, say a month or so. Warn over the risks of driving. We're not diagnosing Meniere's here. That is notifiable to the DVLA, but just it's important to warn people, if you're really, really dizzy, don't go out, be aware of the risks of driving. Are we for time? Oh, actually, we raced through this. Okay.
Okay, for time.
Yeah.
If you've done the bit about the service, we've got a bit more time to catch up. So
yeah, that's fine. Yeah. So otitis externa, we all see this and we all treat it. And generally, I'd say everyone does a really good job. Inflammation of your external ear canal. So basically eczema of your ear, you could say, although it can become infected. Really itchy, can be really painful and uncomfortable. You get a lot of redness. It can extend into the outer, into the pinna, the outside of the ear, and you get a local cellulitis, and it's just really quite sore for the patient. Discharge, I'm sure you've read about this, serous, watery, or purulent if it's infected, not mucoid. Now, if you tell me how you spot the difference between mucopurulent and purulent, it's pretty difficult. Mucoid, the glands to produce this mucoid discharge are in the middle ear. So if you're really seeing mucus discharge, you're thinking more middle ear pathology. I guess that's more relevant in young children. So if you've got a, say, 2-year-old or 18-month-old, they're less likely to get an externa. That's more likely otitis media. So if you see a really young child and they've got really crusty ears, chances are you can't really see in the ear anyway because it's full of rubbish, okay? The chances are it'll be otitis media. So you want to give them antibiotics if they have symptoms of fever and are really unwell. I'm sort of deviating from the slide, sorry. I've thought of something. So a young child with a really discharging crusty ears, say 18 months old, you can't see much in the ear. They're really unhappy about you touching their ear. There's a lot of stuff in the ear. Chances are it's an otitis media. Now, if they don't have a temperature, they don't seem that unwell. They may have been unwell sort of 5 days prior to that discharge. I guess it depends on the clinician, but you would be okay to say, actually, I think the infection is resolving. It's a bit like having an abscess and the pus has come out and maybe the eardrum has burst. You may not even be able to see it. That's not the end of the world. It should, in theory, heal. It normally takes about sort of 6 to 8 weeks to heal. There's nothing you can do at the time. Okay, keep the ears dry. Unless they become febrile, that's when you want to give them the oral antibiotics, okay, for a child, that is, because of the risk of things like mastoiditis, meningitis, those sort of things. But if you can reassure the mum that actually the fact that it's discharging and they probably seem happy in themselves, that is okay. All right, let's just say come back in sort of 6 weeks, see if we can see inside the ear. Okay, so I've diverted a little bit, sorry.
Can I just,
yeah.
I mean, what antibiotics? Are we back to amoxicillin again?
Yeah, for an otitis media, yeah, I would. So going back to otitis externa, things that predispose you to it. So classically, you've been on holiday. It's normally swimming in the swimming pool. The sea less likely because it's not that stuff. I know they put chlorine in it, but it's the holiday pools. Lots of bugs in there. Cleaning the ears. This incessant need to use cotton buds. Don't. Okay, we all know that, but people still do. I don't even know what cotton buds are for, but anyway. Things like eczema or psoriasis, they're typically, it's an extension. So your ear canal, it's an extension of the ear, the skin around your ear. So it's likely that's what it's coming down to. And they itch and itch and itch. And when you put things in your ear and you itch it, you nick the skin. It falls into the canal. It's nice and warm and moist. You then get the water in there from your shower. And then all the bugs love it. And that's where the infection comes. Hearing aids, obviously the person who has a hearing aid needs a hearing aid. I understand that. But effectively, you're wearing an earplug the whole time. Make sure they're taking out at night. They're normally pretty good and they know a lot about their hearing aids. But they will be predisposed to infections. When you have the infection, don't wear the hearing aid, okay, for that 5-6 days, okay. Be wary of the diabetic or immunocompromised because then not will, but then they could have infections such as malignant otitis externa. It's not actually malignant, but it's just that needs proper care through ENT. Okay. Examination, you'd always do that. Check both ears. There's lots of debris and it's a really thin, tight, inflamed canal. You don't need to give oral antibiotics. If you could drop either me an email or go through the ENT referral process and just mark it as urgent. I think that with the number of clinics we have, we could get them in. Oral antibiotics really won't do anything. What we really need to do is either suck out the rubbish with our suction machine, so then you can put the drops in, or if it's really, really tight, you put something called a poke wick, which is I can't think of another way to describe it other than using a tampon. You put it in the ear, then you put the drops in and it expands. It's really, really clever. And so then the patient just keeps putting the drops in this thing and it just expands and then eventually it drops out and then the canal's open. It's very clever.
Do they have to be changed or can it just stay in there?
No. Well, I mean, I would arrange for them to come back. They normally just drop out as the canal opens up. It's really clever. Yeah. So management, tend to use an antibiotic and a steroid. The steroid is to help just decrease that inflammation. Doesn't really matter which one you use, Sofradex, Otomized. I never really know what the pharmacy does or doesn't have at the time. There's no right or wrong, really. If there's a history of perforation, I know everyone talks about ototoxicity. It's pretty rare, and you need to be using the drop for quite a long time to really get that toxicity. But to be safe, you could use a Ciprodex combination. That's absolutely fine. Okay. If it's persistent, or you're particularly worried about, looking at the site of the eardrum and you think it may be cholesteatoma, or as I've said, this malignant otitis externa, just do drop a saline. A cholesteatoma is not a 2-week wait. Okay. It's not urgent at all. It needs to be seen, but you don't need to 2-week wait it. Okay. Keep ears dry. That's so important. So when they shower, put earplugs in. And not just cotton wool, that's a classic. I put cotton wool in my ears. You need to put Vaseline over the cotton wool, otherwise it just acts like a sponge and you're just drawing the water in. Okay. And don't put drops in the fridge. I did have a patient who kept saying when he put the drops in, he went dizzy. And I later found out he was putting them in the fridge. If you put something very cold in your ears, you will go very dizzy. Okay. So don't do that. Put a little bit about earwax. I know it's not really a medical problem, but we see so much of it. So let's just talk about, this is the last slide anyway. It's normal in the majority of cases. So we have earwax for protective function. It waterproofs the ear, it makes it nice, slightly acidic, so that puts off bugs from growing. I'm not doubting the fact that some people definitely have a propensity to produce more wax than others. I don't doubt that at all. Some people's ear canals are slightly more tortuous than others. So there are people who definitely need a bit of help with removing the wax. I've put it's over medicalized. I think we're the only country really, well not the only, but one of the top countries that talk about it and do things.
Our patients are obsessed with earwax.
Yeah, they are. Good history is really important because it's often parents with children. And they can have selective hearing, children can, as I'm sure we all know. Ask about the teachers as well, or if they're complaining of pain. Sometimes it shouldn't be too much, it's more of an irritation. So the reason why it can become painful, if you go swimming or have a shower, if you get water in the ears, either you can get water behind the bit of wax or the water makes wax expand. So for that time when you just got out of the water, children get, oh, my ears really hurt, but it does tend to settle. Now, it may be that there is an infection, or it is the fact that the wax is just expanding, or you've got a bit of water stuck. Okay. So sometimes you get hearing loss, discomfort. And yeah, for all those things, yeah, do feel free to bring them in and we can have a look and try and get it off, get it out. Olive oil. So, and there's no nice guidance on how you soften wax. Again, I think it's because it isn't really a medical problem. But I tend to say olive oil at night, because if you put olive oil in your ear, you go really deaf. So if you're going to send a child to school with olive oil in their ears, it's not very kind when they can't hear, or anyone, an adult for that matter. So if you soften it at night and then use something like sodium bicarbonate or hydrogen peroxide, something that's going to dissolve it in the day. If you let them know it is a bit fizzy, because sometimes they get a bit shocked at the sound, use it for about 10 days, then review. Or if you want to make that referral in the interim, just get them to soften it. It would be really helpful. And as I say, we've got this nurse-led wax clinic now, so it's really useful.
And what about hydrogen peroxide?
Yeah, you can do. For some reason, I've used it a few times, and people seem to say it can be quite painful. Mm-hmm. So I've gone off it and gone back to sodium bicarbonate. Yeah, absolutely.
It's actually olive oil.
The olive oil can be. Yeah, absolutely. So there's no right or wrong.
Olive oil isn't good.
Oh, really? Because they say
the oleic acid tends to actually become an irritant, and you're better off with vegetable oil.
Okay, that's interesting, isn't it?
Yeah, because they're saying it's food grade, but not skin grade.
Okay.
So it might be cheap and chips, but not for the skin.
Okay.
And also, most people have got vegetable oil.
Yeah.
And they don't have to go and buy a fancy.
Yeah, but if you tell them just to use what you have at home, they think,
I know, yeah, but it
can't be. Or they use a massive bottle into it.
It's surprising with some of our patients. The CCG, just so you know, has just actually produced a huge policy on earwax and how earwax should become a medical problem.
I did do a sort of A4 side on what to do for earwax.
So I've got a question. So should
sure.
we now look at your nasal endoscope? I don't know if you want to willing volunteer from the audience for this.
Are people logged off or not?
People are still logged on, but actually we can get into some Q&A in a bit.
Or
but
should
I think
we do some questions first and then this? I don't mind. I'm just thinking of people on the internet. Yeah, sure.
Age again,
Yeah.
for the earwax removal syringing thing.
Yeah, so I talked to Santosh. That's the nurse who does it. So we still do. I still do it as well. I do the suctioning. So she actually does irrigation as well. She just does it with a syringe. So you got to think, if you're referring a patient, I don't have a strict age. First of all, now you can have a 7-year-old who's going to sit there beautifully, or you could have a 4-year-old who sits beautifully. And equally, you could have a 10-year-old who really won't tolerate it. I don't have the suction machine. It's just loud because it's in your ear. It doesn't really hurt, but it's quite disconcerting because you can't see it because it's there. And so for a child, some are brilliant. So it's just a case of, if you can explain to the parents, this is what it is. It's loud. If you think they're going to tolerate it, fine. That's absolutely fine. Oh, well, we're not going that far. I try not to go down as far because wax is only produced in the outer third of the canal, so it tends to be there. If you're looking at wax, I mean, you do get impacted wax because people stick things in their ears and push it back, which is slightly more annoying. Less so with children. Or you think of things like cholesteatoma if it's right at the back, at the top or something. But yeah, so there isn't really an age. That hasn't really answered your question, just because it's about whether they tolerate it.
Sonal.
Do you do removal of foreign bodies?
Yeah. Yeah, things like batteries though need to go in, that because that's dangerous. Yeah. Mm-hmm. But yeah, I've removed all sorts of Lego, beads, cotton buds.
There's a question over here on the right.
Yeah, sorry.
Is there any specific reason why GPs can't remove a bit of earwax with a round?
No, there isn't. So it's just about what you can see, isn't it? So it's completely up to you. It's about knowing where you are in the ear, isn't it? So I have a magnifying glass and I know what you mean, okay? And if you feel confident doing it and you're not going to do too far and you're going to hit the eardrum or damage the external canal, there's no reason why you can't, but it's just about the repercussions in it if something goes wrong. So no, not at all. If you've got something small enough to go through.
We used to have those.
For cleaning, but we haven't got the proper school, the proper instrument that's also round and safe and so on. I don't know. I've never done it here. That's the thing they do in Germany. Nobody bothers about syringing. Actually, the amount of complaints, and there isn't any in Germany anyway, but the biggest amount, but not compared to here, the biggest amount of complaints is about ear syringing, just because of probably wrong handling and secondary infections and the patient.
Yeah, you're right.
And so on. So they stop doing it. There's too much problems, not stopping either. We're not on a big scale. So I was just wondering, and if you see the doctor, I had it done, they seem to be confident, let's have a look at it.
It's completely about confidence and whether or not you can see it. So it's just about the risk, isn't it? Because, and it depends what the person's canal is like, if the wax is just there, then fine, yeah. If you feel that you're safe or got an instrument that's small enough to go through, then.
Do they have them?
I do in the clinic.
So you can get, and Hands of Certain used to have, instead of the black oroscope pieces, they were green scoopy things on the end.
Yeah.
And you could literally just use them to remove the wax.
Yeah.
There's a question: is that a sensible thing for us to do or not? You can bring that back another time. Should we be doing that in practice or not?
Yeah, I mean, it's all about whether it's. So the reason why, I guess, it's not. They don't say just go out and do it. Again, I keep going back to it. It's just the risk of what you can't see. Okay, so if you accidentally use the scooper and hit something, or it's painful, and then you can't actually see beyond there, or the piece of wax is still stuck in there, and they're actually in more pain, but you can't get it out. It's just thinking of practical. But if you want to, I wouldn't say don't try.
Yeah, only certain people do it. Maybe we could have some training sessions, but the same issue comes up with you. Olive oil, they come back anyway, so they say, oh, this is now more uncomfortable. I didn't mind it, and it hurts me,
Get them to see Santosh.
I think that's your answer. Bill,
Just a quick one. You mentioned about this maligninotitis externa, and this is something that since having read, I've not seen any, but that's why my question.
Well, you often might have. Well, no. But yeah, it doesn't look any different particularly. It's more that it doesn't look any different. It's more persistent.
About this? They mention about this mastoid tenderness, and if there's significant mastoid tenderness, think of this. What's your opinion on that?
So I've only probably seen it about once or twice, and actually one of them was when I was doing ENT. Anyway, it's difficult, isn't it, in the community? Like all these things, they always talk about malignant ontostoma, cholesteatoma, because they're the ones you're meant to see. In reality, do you see it? No, I've not. Okay, I've seen a couple of cholesteatomas, but so malignant otitis externa, it's not malignant, it's just persistent. So it's normally caused by Pseudomonas, and it's just that it keeps going and it can well, it can then develop into cholesteatoma. So you start to get bone. So the mastoid bone is right there, right by the ear canal, and you start to sort of erode into the bone. So it can be really bad.
Does it smell bad if it's Pseudomonas as well? Is that another...
It can do. So cholesteatomas do smell really bad, and it's to do with this osteitis that goes in.
Pseudomonas smells bad anyway.
Yeah.
So I was thinking, that's why I was thinking, if we try the first drops like Otomyce or Gentisone, if it doesn't work,
it's not that common. It's not that common. It's not that common. Just because one drop doesn't work doesn't mean they've got a malignant. So
then, you alluded to Pseudomonas. So should we just go to Cipro as the second line then? If the
I often do. Yeah, I often do. You could swab it if you're really worried.
Yeah.
Malignant otitis externa is not it's not that you treat it keeps coming back. It's that if you treat it, it doesn't get better.
Yeah, basically.
Recurrently treating it.
Not just twice. I mean, they normally got it there for a long time.
Long time.
Yeah. Often immunocompromised, diabetic.
Yeah. They often complain of like pain at night as well.
Yeah.
Specifically pain at night, and sometimes in really severe cases they get facial nerve involvement.
That's a lot. Yeah. So that's what you don't want to happen. Yeah. So long time.
Actually, that's just as an update, because I think you need to be updated on this every 18 months, because I can never remember. I know we haven't talked about it, but Ramsay Hunt, what are the current?
Oh gosh, I haven't had that for ages.
Steroids, and if you catch it early enough.
No, it's a diagnosis of exclusion. Yeah, so.
Because it goes, steroids went in and out.
So they do say, and they still say acyclovir, don't they? Yeah, 5 days acyclovir. Yeah, and oral steroids up to 60 milligrams a day.
Yeah, not for Bell's palsy though. No acyclovir for Bell's palsy.
No, Bell's is just steroids, but that's a diagnosis of exclusion again. Yeah.
Any other questions from the floor? Got a whole new set of the room that's appeared over the course of the last half an hour as well.
Great.
We've been very quiet over there. I hope you've all signed in. If there's no other questions from the floor, I haven't been sent any questions from people logged in remotely, so you're obviously not very enthusiastic. You may want to send some questions through over the next few minutes. Do you want to get out your nase endoscope?
Yeah, sure. It's not that exciting. I won't put it in anyone's nose or anything.
Trombone, actually. Okay.
But Danny would love it.
Danny, I have to say, I went and logged into the YouTube outside, and you can hear it. It does work. Come on, guys. Quiet down for the next couple of minutes, please.
I won't do it.
And as far as cleaning goes for nose endoscopes, they can be wiped. They don't need formal sterilisation or anything like that.
We use so there. That's it. Goes into the nose like that. I won't do it.
Fantastic.
Goes all the way down to the voice box.
Do you want to hear what it is?
Okay. Are there any other questions from the floor? People. In which case, Liz, is there anything else you wanted to add onto today's presentation? As far as how can we help you with referrals goes, what aren't we putting in referral letters that we should be putting in referral letters?
I don't think there's anything anyone's not putting in, because actually when, I don't know, if you see a referral letter, you get a vague idea of what's going on, but when you see the patient, you take your own history anyway, so no, not really. No.
Okay. In which case, Lindsay, thank you very much indeed for presenting today. What I wanted to say is that we've sorted out, there's a missing slide, don't worry in that case. We've sorted out the next few months worth of grand rounds. So in December, it will be the third Wednesday of the month. We have Dr. Empson, who is going to give us a grand round on rheumatology. In January, we have got Dr. Anna Gower, who's going to be giving us a grand round on ophthalmology. Both of those are third Wednesday lunchtimes of the month. In February, we've got Dr. Sandeep Randhawa, who is going to be doing urology for us. Now, the third Wednesday of the month, that month, falls in the middle of half term. So we brought it forward by a week. So in February, it will be the second Wednesday of the month. And then in March, our lovely Dr. Tracy O'Shea, who is sitting over here, who is the queen of everything dermatological, will be talking to us all about dermatology. We're all really excited about that.
Do we have a mechanism by which people can email and suggest things they would like to be discussed?
So what we've said is for every one of these questions, the format is relatively similar. So we have a common area within the topic. So today was common problems. We've had new nice guidance on something. We have a little bit about the service, and then we have Q&A. So we encourage everybody to bring along cases or questions that you've got. Today, every one of our online viewers has been encouraged. They've all been given my email address to email me questions to ask Lindsay, but no one has emailed anything through. But we will continue to encourage that. My guess is
it would be helpful because but yeah, I mean,
my guess is the next time we do this, we'll be doing it through a proper WebEx, and so there'll be a live chat on there too, and we may get more questions coming through there that time. But I would encourage all of you guys who've got rheumatology questions for next time to bring them along to Dr. Empson. Today, sitting around the room, we've got Dr. Lindsay Smith from ENT. We've got a trio of cardiologists sitting here. We've got Tracy from Derm sitting here. So this is also your opportunity to meet some of these guys. If there's any other questions about any of the other specialities you want to pick out, I'm sure you may get a flurry of people coming to you, Lindsay, wanting to sit in clinics or wanting to ask you other things. But I have to say, on behalf of all of us, I'd like to thank you very much for this afternoon.
Thank you.
And that has been really useful. And thank you for everybody who has been logged in remotely. There is a feedback sheet remotely. For people that are here in the room, we've had comments that some people haven't had previous presentations. You will all get an email sent out if you've signed that list there with details as to how to get today's presentation, along with previous presentations. And if you're on the list, you'll get a certificate sent out to you as well. Very much.